Hi everyone. Let's discuss chapter 11, abscesses of the periodontium. Just like occlusion, yay, you've had all of this information before. Yay, it's going to be a review. Yay. So, abscesses of the periodontium. Now, new classifications. This is funny. New classifications were added in 1999, which was the previous AAP classifications, okay? And they included then periodontal abscesses as part of the course of the periodontal disease with treatment challenges, and it's named according to location. So we're going to be learning about these. Some of them might be new, but most of them are going to be a review. Abscesses or infection, okay, occurs in the gingival tissue, that marginal tissue or interdental papilla. It's caused by a foreign object. That foreign object could be a kernel of popcorn or a fish bone becoming embedded in that gingival crevice. What happens to that? It's like a splinter on your finger. It causes inflammation. The immune response is then triggered, and it sets a whole set of motions, okay, into motion. So abscesses develop and spreads rapidly for a gingival abscess, usually within 24 to 48 hours. Okay, you're going to see and feel a gingival abscess, rapid in occurrence, gingival margin, gingival crest. Okay, so what are the clinical features? You've got localized to the gingival margin or the interdental papilla. It's painful, it's edematous, it's swollen. There is purulent exudate or pus that may come from the crevice, not necessarily, but sometimes it's pussy. Gingival abscesses usually are located more coronal than periodontal or endodontic abscesses. An endodontic abscess is at the apex of the root. So that's the root canal type of abscess. It's usually just in the gingival sulcus, whereas a periodontal abscess is on the lateral side, and an endodontic abscess is at the apex of the root. What's the treatment for a gingival abscess? You remove the etiological agent by periodontal debridement. That could be careful scaling. It could be using the ultrasonic. It's amazing how much popcorn we find in the course of our scaling. Sometimes there is a hair that's been lodged also between teeth. There have been pieces of nails from nail biters that we've seen. It's just amazing to see what we find inside patients' gums. But anyway, careful scaling. You want to remove that source of infection. Warm saline, warm saltwater rinses. It's not a systemic infection. It's very localized, so that's all they need. Usually resolves very quickly. Rapid onset, rapid resolution, okay, by removing that splinter. So that's a gingival abscess. Then you have a periodontal abscess, which is also called a lateral abscess. That's located in the periodontal tissues or that gingival wall of the periodontal pocket. It can occur in the furcation area or of the lateral aspect of the tooth where a deep pocket is located, but it's not at the apex or the tip of the root, which would then be a periapical abscess. And it's not at the free gingival margin, which would then be a gingival abscess. So a periodontal abscess or a lateral abscess is contained on the side of a tooth, the root surface, where there's bone loss. The patient may come to the office and say something like, I have pressure in my gums, right? It's not real painful, all right, like a gingival abscess. The tooth is often tender, though, to percussion. There's mobility. There's a deep probing depth. Okay, you are going to probe it. And occasionally there can be some lymphadenopathy present. So you're gently probing. Look at this. This tissue doesn't look too bad here, okay, even here. But this probe goes all the way in. You've got your abscess here that you can see now. Is this a lateral abscess or a periapical abscess? So as the dental hygienist with the patients in your room, you're going to be taking a periapical of this area and you're going to be probing it. This is a lateral abscess, probably more related to the furcation of that tooth than anything. look at these red areas. And this is where what you're going to be looking at when you're doing your EO-IO too. You're bringing the lips up and you're checking for these things. Periodontal abscesses are oftentimes bacterial infections. It's not that piece of popcorn. It's a bacterial infection leading to the formation of suppuration, which is that pus or purulent exudate. It's often associated with pre-existing periodontitis. They've got pocketing. Look at this though. Calculus is usually found on the root surface. They usually happen post-scaling. Right, post-scaling. There's something called post-scaling periodontal abscesses. If we don't debride that root surface enough, we've woken up all of that bacteria. The calculus is still there. There's bacteria on the calculus, and you're going to get an abscess. So that is why, my friends, we do not do an initial scaling or a gross scaling on anybody. We only start what we can complete. So that might be one tooth scaling to completion, two teeth scaling to completion, a sextant scaling to completion. So you're not going in and ultrasonicking, for example, the entire mouth and then trying to hand scale and then time runs out. Only start what you can complete. You scale to completion. So bacteria found in the pus, we talked about some of the bugs, is your P. gingivalis, okay? That is your standard periodontal pathogen, Fusobacterium, and P. intermedia. Now that P. intermedia is with pregnancy gingivitis and some of the other ailments, okay? It's one of the red complex. It causes destruction of the periodontal tissue as well as bone. Not only the bacteria, but remember that immune host response, those prostaglandins, E2 and everything else, the interleukin-1 is all being set up for destruction. So how do you manage this? The first phase is to manage acute signs and symptoms. Sometimes the patient's pretty asymptomatic, especially diabetic patients. They seem to have a high tolerance for pain. They get a lot of abscesses. They don't even know they're there. It's interesting, to say the least. But drainage must be established to drain the pus, and that's usually through the pocket entrance. Right, so if you have a patient with a periodontal abscess, okay, they've got communication from here all the way up to here. But think about all that junk that's here at the gingival margin. That junk is very sticky, okay, and it acts like a glue, so it's difficult to get in there. So sometimes you have to break this up with a probe or gently with the scaler to get into where that abscess is so you can help drain it. Sometimes you're placing gutta percha, a little point in here, and kind of popping that pimple so the pus can come out. If the fistula is draining, the patient oftentimes doesn't have any pain because it's releasing the pressure. So an acute periodontal abscess that is not treated or resolved becomes a chronic periodontal abscess. So if the patient doesn't know they have one or aren't seeking treatment, that acute abscess becomes a chronic one. And with chronic, symptoms may not be as evident as with the acute because they're just kind of used to it. And we have to be able to differentiate between a gingival abscess, a periapical abscess, or which is the endodontic lesion, or a periodontal abscess, which is that lateral lesion. So here, what do you think it is? Well, we won't know. It's kind of at the gingival margin. We don't know where the bone is, but look how far that inflammation's going. It's not just localized to the papilla. Look how red this area is here. You'd be probing and you'd be taking a periapical and getting all of the data collected for when the dentist comes in, they can make that final diagnosis. Inflammation here. like there's some chemical reaction going on as well. Talked about a gutta percha point. Look at these three little whiteheads here. Our tendency is to want to press on it and watch it gush because we're sick people, us dental hygienists. We can't help it. But this is a gutta percha point that you place in here, and then my employer had me place another gutta percha point going in this way as well into the pocket as far as I could go. So then they could see if the gutta percha point came here and here, if they communicated with each other, it might be a combined lesion versus just a periodontal lesion. Is this an endodontic lesion, a periodontal lesion, or a combined lesion? Table 11.1, okay, gives you the criteria for each. So be familiar with that table. Everything you need to know. Gingival abscess, you're not going to see anything radiographically versus the other. Then we've got our pericoronal abscesses or pericoronitis. Remember that erupting third molar, the infection involving the gingiva adjacent to a partially erupting teeth. It's usually the mandibular third molar, but we can sometimes see it in the second molars of preteens as well. That gingival flap or the operculum overlying that erupting tooth is usually red, tender, edematous. The patient can't bite down. It's sore, okay, very friable. You blow air and it just kind of goes blah, 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 like that, okay, very friable. Food can get impacted in here, bacteria. Sometimes trismus, limited jaw opening, is a symptom. Difficulty swallowing, dull ache. Treatment is either extraction of the tooth, especially if it's a partially erupted or impacted wisdom tooth, or removal of the operculum through scalpel, electrosurge, heat, or laser. Pericoronitis. You can bet this patient isn't able to bite down. That's swollen. Primary herpetic gingivostomatitis. Now remember, we've talked about that when we're ruling out some of the necrotizing gingivitis as well, okay? Is it necrotizing gingivitis? Is it primary herpetic gingivostomatitis? Right? It just looks angry, doesn't it? But look at all of these tiny little multiple vesicles here. It's like canker sore after canker sore. So again, box 11.1, we had table 11.1 and box 11.1. Tells you what to do. So abscesses are bacterial infections. It's important to determine the origin of the abscess. Something caught in there? Is it residual calculus? Is it bacteria? We want to establish incision and drainage of the infection or removal of whatever it is that's causing that gingival abscess. Systemic antibiotics are only needed if there's systemic involvement. Is there lymphadenopathy? Is there fever involved? Otherwise, it's a localized problem. 5 to 10% of the patients initially infected with the herpes simplex develop that primary herpetic gingivostomatitis. That usually happens at a young age, but only 5% of the patients get that. It's not everybody who has herpes simplex 1 is going to develop this primary herpetic gingivostomatitis. You're going to be getting more into this with pathology. So let's look at some questions. Which of the following may also be referred to as a lateral abscess? Gingival, periodontal, endo, or pericoronal. Okay, and it's the periodontal abscess. Which of the following is a localized infection involving the gingiva adjacent to a partially erupted tooth? Partially erupted. Pericoronal. Treatment of a periodontal abscess involves opening the pocket with a curette or a probe, which can be accomplished because the tissue is not very friable. And the statement is correct. You want to, that's opening, incision, and drainage, but the tissue is very friable, okay? It's very loose and wobbly and jiggly, kind of like my upper arms. All right, guys, that was a review of periodontal abscesses, the end of chapter 11.